What initially we thought was that we can, kind of do as epithelial abrasion, removal of epithelium, and let the riboflavin absorb in the cornea, and that will treat the keratoconus wonderfully. And we saw that it is a wonderful, results. But then there were situations where we were seeing ectatic conditions or ectasias, or a situation where post-op ectasias, post-LASIK ectasias occurring, where the corneal thickness is more than 400 microns, and there was a very mild, myopia or myopic astigmatism. And there I started treating with the PRK. So what I did was did PTK for the removal of epithelium, and then PRK for removal of little bit of correction of astigmatism and little bit of correction of myopic correction. And then I found that the results of this is much better, because then stroma is also exposed and the absorption of riboflavin is much better. So in those cases, and along with that, I have also done a lot of cases of C3R with Intacs, and here I am going to present those results and my experience on that. Intacs are small prescription ring inserts that are implanted in the cornea for correction of conus and mild myopia. Basically, they came in for myopia, but later on we found that they are better for conus conditions, and they redistribute the stress to flatten the cone, and the conical, when the ring is inserted in the cornea, the central cornea becomes more flatter and round curved. So, and also we found that there is another procedure which may be required to provide additional mechanical strength for better vision, and that is where C3R came into picture. So maximum K up to 57 or best corrected visual acuity of 6/24 or better would give us a fantastic results with the Intacs and the corneal collagen cross-linking. These are the Intacs, as you can appreciate, they are very small, in the range of 6 millimeter curved small rings, and they are particularly well suited for those who have been turned down for laser vision. So Intacs basically were meant for myopia correction because of the thin cornea, but later on they were also used for treatment of keratoconus. And they are FDA approved even for pilots, right? So this is how they are put. This is the hexagonal Intacs placement, which is at 70% of depth in the cornea, and in this stroma it is sitting right in this stroma. And you can confirm it on the slit lamp after just after the placement, and they can correct kind of up to 5.75 according to the nomogram provided by the company. So these are the nomograms for post-LASIK ectasias. And along with Intacs, if we do corneal collagen cross-linking, which is a minimal invasive method to improve biomechanical and biochemical stability of the cornea, the progression of keratoconus and corneal melting can be stopped, as I said in the previous talk, and treatment is cheap and easy to handle, and 400 micron of corneal thickness to prevent the endothelial damage is important. So combined cross-linking and Intacs, what they are providing is cross-linking stops the progress and Intacs flatten the center in the keratoconus. Thereby combination of two procedures gives the best of both worlds and provide long-lasting stability and improved vision. And here you can see, this is the picture where you can see the conus in the picture, and especially if you look at the C here, the peninsula, which is diagnostic of the keratoconus in all these cases. And this is how it becomes after putting the Intacs in this particular eye. It becomes round, flatter in the center, and the patient gains quality vision after doing so. What we are achieving is we are stabilizing the cornea, and also we are flattening the cornea at the same time. In PRK, the ultimate corneal thickness remaining over 400 microns of stroma, a PRK correcting 50% of astigmatism gives nearly complete correction of astigmatism and a cone flattening more than conventional C3R, because what we are exposing is the stroma directly, So that is why the flattening is much better. The astigmatic correction is also superior, and we are correcting little bit of astigmatism with PRK, and we are doing the C3R along with that. And here you can see the results of C3R with PRK are much better than C3R alone, provided you can get the PRK. After the PRK, you can get a corneal thickness of 400 microns. So here are some topographies which show wonderful flattening of the cornea, and this is what we are doing in majority of our cases, where we can achieve a 400 micron thickness after removal of epithelium, after the PRK, and still we are left with a 400 micron corneal thickness. Then we can definitely do a PRK. Or in other cases where we cannot achieve a 400 micron thickness, a combination of C3R with Intex is an excellent proposal. Of course, C3R will make the cornea harder, so it is better to do Intex first and then do the corneal abrasion and then do the C3R after as a second sitting. So that's how we are doing it. Thank you for your kind attention.